The choice between a mechanical and a bioprosthetic valve is increasingly viewed through the lens of lifetime management, shifting away from a simple age-based binary towards a more nuanced assessment of patient longevity, lifestyle, and the feasibility of future interventions. Current guidelines emphasize shared decision making, but several objective clinical pillars remain central to the selection process. Mechanical valves are generally favored when durability is the primary concern and the patient can safely manage long-term anticoagulation. Durability of mechanical prosthesis is virtually lifelong. The risk of structural valve deterioration is negligible. Anticoagulation requires lifelong vitamin K antagonists, usually with a target INR of 2 to 3 for aortic positions and 2.5 to 3.5 for mitral positions. Ideal candidate: patient aged less than 50 for aortic or less than 55 for mitral. Patients already on anticoagulation for other reasons like atrial fibrillation. Patients with a high risk of rapid bioprosthetic calcification like end-stage renal disease or hyperparathyroidism. According to a comparative study published in NEGM in 2017, long-term mortality benefit associated with the mechanical processes as compared with the biologic processes persisted until 70 years of age among patients undergoing mitral valve replacement and until 55 years of age among those undergoing aortic valve replacement. Bioprosthetic valves are selected to avoid the lifestyle constraints and bleeding risks associated with warfarin, acknowledging that a re-intervention will likely be necessary. Durability limited by structural valve degeneration, which can typically occur 10 to 15 years post-implantation, though newer generation valves may offer improved longevity. Anticoagulation only required for the first 3 to 6 months post-operatively, aspirin or vitamin K antagonists, unless other indications exist. Ideal candidate: patients aged more than 65 to 70 years. Patients with contraindications to long-term anticoagulation or high bleeding risk. Women planning pregnancy to avoid the teratogenicity of warfarin. Patients whose lifestyle or occupation makes anticoagulation dangerous, example contact sports, manual labor. For patients aged 50 to 65, the decision is highly individualized. The focus has shifted toward the valve-in-valve potential. Aortic position: if a bioprosthesis is chosen in a younger patient, the surgeon must consider the sinus of Valsalva anatomy and coronary height to ensure a future transcatheter aortic valve implantation is technically feasible. Small annulus: in patients with a small aortic root, a mechanical valve or a root enlargement procedure may be preferred to avoid prosthesis-patient mismatch, which significantly impacts long-term survival. Summary of clinical considerations: durability, excellent for mechanical processes, more than 25 years or more. For bioprosthetic, limited 10 to 15 years. Thromboembolism, higher risk for mechanical prosthesis, lower risk for bioprosthetic. Anticoagulation, lifelong warfarin with INR monitoring for mechanical, short-term or none with bioprosthetic. Reoperation, rare with mechanical, likely in younger patients with bioprosthetic. Infective endocarditis, higher morbidity with mechanical processes, slightly better salvage potential for bioprosthetic. Emerging trends: TAVI versus SAVR. The expansion of TAVI into lower risk and younger populations is influencing the initial choice of a surgical bioprosthesis, with many clinicians opting for TAVI-friendly surgical valves to simplify future transcatheter redo procedures. On X valves, these newer mechanical valves allow for lower INR targets 1.5 to 2 for aortic after the initial 3 months, potentially reducing the bleeding burden of traditional mechanical options.